So my name is Chen, and I'm assistant professor in the Department of Pharmacology in UC Davis. And I'm also the director of the animal models core in the Cardiovascular Research Institute. Okay, and then so before that, I maybe just give a little idea to let you know what's the animal models core doing in UC Davis. Basically, we help other investigators to do research if they need complicated surgical induced animal models, then we will do that for them. So they just pay for the charge, the cost for each animal. And so by that way, they don't have to worry that where to find a great surgeon to help them to do a consistent surgical model. And so we also provide training. And so in the future, if you guys need any technical support, then we can do that. So we can issue letters for you to apply your grant, then to describe that all the surgeries would be handled by our core. And so the reviewer of your grant won't doubt that are you really able to do the surgery or not, this type of concerns. Okay, and yes, we also do other surgeries for private corporations. And so, but our main job still doing to help the people on campus. Okay, and then, so I'll just give you guys a little information about myself. And so I get my DVM in Taiwan, and then after that, and I do the master degree in Taiwan too. Then so I was, my topic is clinical small animal surgery and also microsurgery. And that master training is similar to the residence program in United States. Then so we just specialize our skill by taking a master degree, but it's also need a dissertation for that. Then after the 2-year military service, and I came to United States and tried to get my PhD in the VAS school in UC Davis. And at that time, my topic is about transplantation and some immunosuppressive drugs for companion animals. Then after that, I did my postdoc, and my interest of my research is potassium channel in neural inflammation, and mainly focused on a stroke study. Okay, and then I started doing my microsurgery training like 20 years ago when I was in my master program, and I actually learning the microsurgery skill from the most complicated one. So I started from learning doing a whole length transplantation. So we have to sew back the blood vessel, nerve, muscle, and reconnect the bone. And so this is the dog that we try to do. This is the sound okay, or you guys might, someone says that it's some noise, but if my sound becomes super unclear, please let me know, okay? And then, so this is a dog that we did a transplantation, and so his name is Cookie. Then so you see that he lose one of his leg in a car accident. Then we transplant a leg, the forelimb for him. And then we finished the project with my mentor, Dr. Ye, and then also my two senior colleagues, Dr. Liao and Dr. Liu, okay? And so after that, then I started to do different type of animal models, like the heart transplantation in rodents and renal transplantation, artery transplantation. And right now, in the core, we are mainly doing cardiovascular related animal model. And so we do the ischemic model in mice and rats. Then we also do the TAC surgery and LAD ligation, and also implanting telemetries for other investigators. Okay, then so let's go back to the topic of today. Is the middle cerebral artery occlusion, which we also call it MCAO. And then why we are doing this models is because it's focal ischemic stroke models, which we want to mimic human patients' cases. Okay, and then ischemic strokes actually almost 85 to 87% of stroke cases are ischemic model. And then in human patients, lots of cases are results from middle cerebral artery occlusion. Okay, and then so, but even it's a very serious healthy problem all over the world. But so far, on top of the surgical approach to remove the clots and the treatment, the medical treatment for the acute ischemic stroke is very limited. And so, so far there's only one FDA approved drug, RTPA, approved for use in a human patient. And also the treatment window is very short. And so that's why lots of studies still need to understand more the stroke physiology, pathology, and try to develop an appropriate treatment for acute ischemic stroke. Okay, and so that's why we also try to do the middle cerebral artery occlusion to mimic human patients' condition. And then here's just a simplified time course of ischemic stroke. And so you can see that, let me go to, then so when stroke happened in the first 4 to 6 hours, the blood-brain barrier was still intact, but the brain will start to suffer from ischemic factors, and also the edema would happen, and acute inflammation will also happen. And after the doctor diagnosed that you get a stroke, and then they might do the surgical approach to remove the clot or try to give you the RTPA. And then usually their goal is try to do to make the reperfusion happen, so your brain tissue can start to get some oxygen and the nutrient back. But when the reperfusion happens, and your brain will start to suffer from reperfusion injury, and there will be lots of microglia activations, and some chronic inflammation will even last for months to years. Okay, and then so for the time course, you can see that no matter you get treatment or no treatment, eventually your brain tissue will start to get some reperfusion. So there are two important factors here. Is one, when we design our animal model, we should, of course, we should have occlusion. Then we should also get the reperfusion, because that will mimic more the realistic situation for human patients. Okay, so where is the middle cerebral artery? And so I found two pretty pictures from the Washington University's website, and it shows you the brain blood supply, and on the left side it's from the base view of the brain, and then you will see that here is the circle of Willis, and then the middle cerebral artery is actually coming out from here. Okay, so for both sides, you'll get the middle cerebral artery. And if you look from the top of the brain, then you will see the middle cerebral artery is coming out from the sides, will coming up and have branches here. And so you can imagine that if you have occlusion on the middle cerebral artery, the main infarct area will be somewhere around here, okay? And then so by this way, then we can try to generate the focal ischemic stroke model, okay? And the advantage of this type of model is you also have another side. The other side, the contralateral hemispheres could be your internal control for your study, okay? Okay, and so middle cerebral artery occlusion, actually, you can use many different approaches to make it happen, okay? And I just list not all, some of the models that are most used in the field. And so the first one is just by the craniectomy. So you would open the skull and find the location of middle cerebral artery. Then you either use a cauterizer or just ligate that. Okay, then so that's one method. And then some people also develop a less invasive method to use the photothrombosis way to do the middle cerebral artery occlusion. So they will inject a photosensitive dye into the blood vessel and then use a cold light source to illuminate the middle cerebral artery. And then that would activate this photosensitive dye, and the dye would start to damage the endothelial cells. Then eventually it would cause the clot forming in there. Okay, then so that's the other way. And then another popular way is the intraluminal filament occlusion. Intraluminal filament occlusion model. And so this is also the model I'm going to show you today. And then so intraluminal means inside the lumen of the blood vessel. And so the way for doing that is to put a filament into the external carotid artery, then guide that filament into the brain, to the base of the brain, okay? And then we hope that would block the origin of the middle cerebral artery here, okay? And then there's also an embolic stroke model, and then so people would use the blood and then to create blood clots in vitro in the lab. Then after that, inject the clot back into the brain and to make a ischemic stroke. And some people would also try to use the vasoconstrictors to make the middle cerebral artery contracted. And so by that way to induce the ischemia. And then there are many different ways to do that to make the middle cerebral artery occlusion. And then so it's all depends on what the main purpose of your project is. Okay, then so you will need to consider which would be the best way to do the ischemic stroke. And then here is just a paper, and then they discuss the advantages and disadvantages of different rodent models. And then we prefer to use the intraluminal occluder model is because it's more mimic the human ischemic stroke. And also the animal will stress less because you don't have to drill the hole on the skull, okay? And we do the surgery mainly on the area of the neck, okay? And then so by that way, we can prevent the surgical induced inflammation on the brain, and we can also make the neurological evaluation easier, okay? And then another advantage is the reperfusion is highly controllable, and then you just have to pull out that filament, and then we can get the blood supply back. Okay, and so then again, then this way is the intraluminal way, and this gets many advantages, but depends on what you're looking for. Because for example, if you're looking for thrombolysis study, and then you probably shouldn't use the intraluminal method. You probably should use the embolic stroke model. Okay, then so just need to look into what you're really asking for to pick up the right model for your study. Okay, and then so for the reversible middle cerebral artery occlusion, and so the bottom line is we try to insert the filament into the internal carotid artery. Then we insert that filament into the brain. Then we hope the tip of the filament would block the origin of middle cerebral artery. And the right side is just like a simulation to show you that what's probably really happening in the brain. Okay, then so here's the middle cerebral artery, then you want to insert that here, and then hope your tip will block it. Okay, and then if you get the experience to put the catheter into rodents' blood vessel, then you probably would know that the blood vessel that you insert the catheter, you have to ligate it. Okay, and then so in order to save the common carotid artery, so some people, they develop the method to insert the filament from the external carotid artery. Okay, then so by that way, the filament can come in from here, then go up into the brain. And so by that way, you don't have to ligate the common carotid artery. And so that's also the way what I'm going to show you today. And the occluder is important for this model. And we have been doing rats and the mice a lot. Then so we figure out the best size of occluder for our study. And then, but again, it all depends on what strain of animal and what's the age or body size of the animal you're using. And so there is no single answer to tell you, oh, this is the suture size you can use. You have to try that in your lab and to figure out what's the best size for your study. And also depends on what you're looking for. And you also have to decide how long the ischemic time you should have. And if you give the animal too short of ischemic time, and the animal is not going to develop decent stroke. But if you give them too long, and they probably would not be able to take it. They might die on the table or in the first 2 days. And so the differences between common carotid artery insertion or from the external carotid is just like I said. And because there are still some branches will rely on the blood supply from common carotid artery. So if you insert your filament from the common carotid artery, you have to ligate it because you need a suture for holding your filament in position. That means you're also 100% blocking the blood flow in common carotid artery. But if you insert that from the external carotid artery and you just ligate the external carotid artery, your common carotid artery can still remain the same. And usually we would use the animal, for rats, we use something around 200 grams. And in mice, we go by age, we use something between 16 to 20 weeks old. But right now, we're also doing aged animal up to 80 weeks or 90 weeks old. And then we figure that out, the same size seems fine. Because probably after 20 or 20 weeks old, the brain size, it does not really change too much anymore. They might still gaining weight, but you will see basically the accumulation of other stuff like fat or muscles on their body. And so actually, for our experience in mice, for rats will be different. Rats would grow really fast, okay? But in mice, from our experience, once they become adults, then we use the same size of occluder for that. Okay, then so for the occluder filament here, so basically the core would be nylon suture. And then, so in rats, usually we would use the nylon suture size is 4/0 nylon suture. And in mice, we use 7/0 nylon suture. And for the filament, for the tip part, for rats, we would use the 0.43 millimeter thick. And in mice would be 0.21 millimeter. And for the length, in rats, we use 2 to 3 millimeter long. And in mice, we use the 1 to 2 millimeter long. And then way before, probably 10 years ago, then we starting with use this homemade one, the heat blunted nylon suture. And so someone just raised their hand, then so you don't have to do that. Just type your question in the chatting area, okay? Then so I will try to answer that. Then if not, then you can put if I miss that, you can put your question in the Q&A, then I'll answer that. I will try to answer all your questions after the demonstration, okay? And so back to the topics, we try this homemade heat blunted suture before. For permanent occlusion, that works well. But if you want to try to do the reperfusion, that's never happened. Okay, and so we switched to the commercial available suture that get the nylon suture, get a Teflon or rubber coated tip for that, and it works perfectly for us. Okay, and then so the suture part I already explained a little bit. Then, but they here raised another question. Then how do you know your suture is really blocking the middle cerebral artery? Okay, then if you do not insert far enough, you're not going to induce any stroke. Then if you insert too far, and you might damage your blood vessel. Okay, and then before the laser Doppler developed, people just based on their experience, they would insert the filament by length. Okay, then so in rats, they say, well, you probably insert somewhere around 1.8 centimeter from the bifurcation. And in mice, you insert 0.9. Okay, and then some experienced surgeon would say, oh, you just keep insert that until you feel resistance. And then, but from our experience, then even we are using inbred animals, they suppose should be genetically identical, right? Then, but their blood vessel anatomy is always different. And then it's also depends on different strain of animals. They have strain specific variation of their blood vessel anatomy. And so since our core is providing surface for charge, so we have to give our clients quality control to show that we really make that happen, okay? And then so the way we do that is we use the laser Doppler to monitor the cerebral blood flow, and then we will start to measure the blood flow from the very beginning, even before we insert the filament. So we can get a baseline reading here. And then when we prep after the preparation, then when we insert the filament, and then we do not insert by distance. We all rely on the laser Doppler reading. And so when the tip reached that point, the origin of middle cerebral artery, you would see a huge blood flow drop here. And then we would still keep monitoring its blood flow through the ischemic time. And when we pulled out the filament, then we would see the reperfusion happened. Okay, then so we do not really wake up our animal after we insert the filament. But we do have 3 probes, and so we still can manage to do 10 to 15 MCAO a day. Okay, and then for laser Doppler, it is very sensitive to the location, the condition, and also the angle that you put on the skull. And then so when we first get the laser Doppler machine 10 years ago, we just try to put the animal facing down and measure, have our probe, you know, holding here, then measure that, get the baseline, then we flip the animal, start to do the surgery. Then we feel like, oh, we are almost occluded. Then we flip the animal back, then measure the flow again. And then you will see the blood flow reading is all over the place, and it's not really very accurate. So we develop a way to, we will glue an adapter on the skull right on top of the territory of the middle cerebral artery. And then this adapter is like a cone shape, and then our needle probe can insert into the adapter, and then so by that way, we can keep the laser Doppler probe to measure the exactly same spot with the same angle all the time. And so right now is what we do now. And usually the percentage we get of occlusion would be 68% to 80%. And then some people say it's raised, says that then they only go down to 20%, it go down to 50%. And sometimes it's because your filament is not big enough. But I guess sometimes it's because you do not put your probe at the right spot, okay? So doesn't mean your animal doesn't really get that reduction of cerebral blood flow. You're just measuring the wrong spot. And that's the possibility. Then so there are many different factors would cause that. And then from our experience, we have done more than 1,000 animals. And from our experience, once you reach that point, you get a big drop, and no matter how far you insert more, you are not going to get more drop, okay? You are just going to damage the blood vessel, okay? Then so that's what we stay with now. Once we hit that huge drop, then we stop inserting. Otherwise, you will never be able to get the reperfusion well. And then so the best spot is showing that on this on the slides you see that. Then so it's for mice, you want to get it as close as to the margin of the skull, and the reason for that is because, like here, if the bridgma is somewhere around here, okay, and here will be your middle fusion line, and like that, okay, and then so if you do not put that as close as to the edge of the skull as possible, you are going to measure somewhere some area that still gets the blood compensation from different blood vessels. Okay, then so that's how we make sure and keep the consistency for our model. Okay, and then I will show you where I put the adapter later. And the probe we use is the needle probe, is because the needle probe can provide better penetration. Okay, then so on the market there are some other treatable, trimmable probe that you can trim it off. Okay, then but it's only major. It cannot really penetrate as good as the needle probe. So actually we use needle probe. So since we use needle probe, so we need a probe holder, the adapter for holding that. Okay, and then here's just the instruments that I use. And since I learned from microsurgery, from most complicated one, to do the blood vessel reconnection. And so the instrument I use is actually also the instrument that human doctor use for their microsurgeries. Okay, and so I'll have an instrument beaker with saline in there, because from time to time you have to moisturize your tissue. And I will have 3 pairs of scissors. Then so 1 pair for skin, another pair for suture, and the other pair for cutting blood vessel. And I will have 2 same jewel forceps, and to do the tissue dissecting, to isolate blood vessel, make knots, and have one Edison forceps for holding skin, and one applier of blood vessel clamp, and two small blood vessel clamp, and three magnetic retractor for that. And for supplies, we will use 6/0 nylon suture. Oh, sorry, 6/0 steel suture for ligation and holding the filament. And then we use this absorption triangle for my surgery, because the opening is kind of small, and so this triangle tips can help you really reach the spot you want to reach. And if you are doing rats, you can use Q-tips without problem. And then of course you will have to use gauze. And then the filament we use, and then RWD, they can customize different sizes of occluder for you, so you can talk to them to give you the best size for your animal. And then we will have an adapter for holding our needle probe, and we'll use super glue to temporarily holding the probe, and we will apply dental cement to secure the probe on the skull. And then when we finish the surgery, the probe can be peeled off super easy, and then it won't cause any tissue damage. Okay, and so right now I'm trying to walk through what we are going to do, doing step by step in the surgery. And then I will go to the last slides to let you see what we want to achieve. Okay, and then so what we want to achieve is we want to insert the filament into the internal carotid artery, and then we cut it off so we can rotate it down. And then after that, we can insert the filament and let it get into the internal carotid artery. Okay, so in order to rotate down the external carotid artery, we have to trim the branches attached to that. Okay, and then during the surgery, then you will see the vagus nerve over there, and then there will be branches running along the blood vessel. Then so you have to isolate all these blood vessels from its surrounding tissue, so you can ligate or apply the temporary blood vessel clamp safely. Okay, and then so after we attach the probe on the skull, then we will rotate the animal to supine position. Then we will make an opening on its neck from the midline. And the first thing you will see will be two big salivary glands. Then so you want to dissecting between two glands. And then after you retract the sternomastoid and also pull down the sternohyoid muscle, then you would be able to see this blood vessels and nerve. Okay, then put this simplify is something like that you want to identify. So you will see your vagus nerve here, and then you will see a pulsing common carotid artery. Then you will need to try to identify the bifurcation and then isolate the external carotid and the internal carotid. And then you will need to find a branch called the thyroidus. Then so you have to ligate this. And in rats, you have to deal with the occipital, otherwise you cannot rotate the external carotid artery down. But in mice, you can ignore the occipital. Then since it's very close to the bifurcate, and also because of the size of the blood vessel, and so you can leave that alone. So, and then again, our goal is try to put a filament into the external carotid artery. And then so you need to ligate the external carotid artery through the and then we will use the bipolar to burn the branches, then cut it, and then you will need to have a loose suture around the external carotid artery, okay? And then next step, before you make an opening on the external carotid artery, you need to make sure all the blood supply to this area has been blocked. And so we would put a temporary blood vessel clamp on the internal carotid artery and common carotid artery. And after that, it's safe to cut an opening. And you don't want to cut it through, and you just want to make a hole big enough to be able to insert your filament. And once you insert the filament, you can make this knot a little bit tighter to prevent bleeding, but you don't want to make it super tight because eventually you need to push this filament. So if you make that too tight, then you cannot push it anymore, okay? And so after you make this tight enough, and then you can cut the external carotid artery through. And then after that, you can rotate this down, okay? And then in the internal carotid artery, actually there's a branch called tergopalatin. And for beginner, it's very easy to get a filament into the tergopalatin. And how would you know that you get into tergopalatin? Then you will feel that you can only insert halfway, then you totally get stuck. Then you cannot insert anymore. And that means you get into the tergopalatin, okay? And then, so you just need to make this to the right angle, okay? You want to make the tip always head pointing to the head. And so by that way, you can guide the instrument, the filament into the first branches going to the left side, which would be the internal carotid artery, okay? And then this, this cartoon is based on the scale of rat, okay? Then in mice, it will be more difficult because it's super small, okay? And then even the filament tip we use is going to be only 0.23 thickness and 1 to 2 millimeter. In mice, it's going to be look like this long, okay? And so you cannot really put it all the way. So you have to tie it in the middle. Then after you rotate it, then you push everything in, and then you make the knot tight again. And I will show you how to do that in the demonstration, okay? And then so if you follow everything, and then after you have performed 50 animals, then you'll become more consistent. And then so for now, usually most of lab will use just become adult animal for study, and they only use male animal. And then right now, one of my projects is try to see the differences between, we are testing a compound in different gender and also in aged animal. And so we have tried use the same method for adults, male and a female. And we also try to do 80 weeks male and 80 weeks female. And then we can get pretty consistent infrared area. And then also the survival rate for adult animals, it's pretty high, almost 100%, unless some surgical mistake has been made, okay? then if we do not make any mistake during the surgery, the survival rate in adult animal almost 100%. And in aged animal, and then the survival rate is about 70%. And so to us, we right now we do not use TTC staining to evaluate our stroke infarct area because our study have to keep the animal alive for 7 days. And then so what we do now is we use the MRI to do the evaluation of infarct area. And then the on-site demonstration sections, now I'm not going to take the brain out because we do not have TTC. We didn't use that for a while, okay? And then, so this is just the images from the T2 weighted MRI. And so the two slides, one is the 3 millimeter from the olfactory bulb, and then the other one is the 4 millimeter from the olfactory bulb. And then so I outline the infarct area for you to see, and then the pattern is pretty consistent. Okay, and the good MCAO suppose should only have something like this size. If you see that your infarct area extended to the base, and that means you're damaging the blood vessel down there. Okay, it's either your filament is too stiff, or you just need more practice. You need to be more gentle. Okay. Okay, and then so right now I want to switch the gear to talk about the non-invasive in vivo measurement of cerebral blood flow. And so in clinics, you can use the MRI or CT or ultrasound for doing that. But for basic research, and because of the size of the animal, then also the budget issue. And so right now, lots of people is actually using laser Doppler or the laser speckle contrast imaging. And also, some people would use the multiphoton for doing that. And for 16W and 18W means their age, okay? 16 weeks old, so they are 4 months old. 80 weeks old means they are almost 2 years old, okay? And then, like I just showed you, we will use the laser Doppler for quality control, you know, but if you want to do more blood vessel kinetics study and laser, there's a huge limitation for laser Doppler. And because it's only measure a single point, okay? And then in mice, you don't have to make the skull thinner, then the laser can penetrate through. But even if it can penetrate through, you still cannot really tell that if it's on the blood vessel or on a specific region that you want to study, okay? And what you are going to get is only going to be like a float curve. And when the experiment done, and it's done, the curve is the only thing you get, okay? Then, but for laser speckle contrast imaging is different. And then of course, then there's no contact. You know, for laser Doppler, you still have to let your probe attach to the skull. But for laser speckle contrast imaging, it's no contrast, it's hanging on top of the animal, okay? And then so, and then it can provide multiple outputs. You can get video, you get images, you get the blood flow data curve like the laser Doppler. And then you can also do diameter analysis, okay? And then another advantage is can do the whole field imaging, okay? Not just single spots. you can get the whole brain. You see two hemispheres, okay? And then it also provides real-time measurement. And so there is another system called laser Doppler imaging system, okay? Then it will have to scan, okay? And then, so what would you get would be assumption of a period of time. After that scan, you get one image. Then you get the flow data. And then you get another scan, then you get another results. But for laser speckle contrast imaging, you are going to get a real-time measurement, okay? And then another good thing is you can measure as many as ROI you are interested in, okay? You just need to mark the area, the ROI you are interested in on the screen, okay? Then it will give you that blood flow curve, okay? And for laser Doppler, it depends on how deep your pocket is. If you get 3-probe system, then you can measure 3 points. If you get 4-port system, then you can measure 4 points. But for laser speckle, you can measure as many as you want. And then the best thing of the laser speckle is you can reanalyze the data, okay? Then so it's based, it's just collecting all the imagings, the pattern of the laser speckle pattern, okay? And then so after you collect that, you can go back to reanalyze it. Say, for example, then you forget to measure one ROI, then if you are using laser Doppler, when the experiment done, you're done. And if you want to measure another area, you have to do another experiment to use another mouse, another light to get it. But for laser speckle, if you make sure all the condition goes perfectly, you can reanalyze that your data for any other new ROI you are interested in. Okay, so then, but I still want to say the laser Doppler and the laser speckles, they're kind of like orange and apple. Okay, you cannot really say which one is better because the laser Doppler provides deeper penetration. Okay, then so if you just going to do the MCAO and you don't care about all this blood vessel stuff, then you probably should use the laser Doppler. But if you are very interested in reperfusion and also small blood vessel physiology, and then you should use the laser speckle, okay? Okay, then so before I start the demonstration, I would disclose that all the procedure I'm going to do now has been reviewed and approved by the IACUC committee in UC Davis. And from now, then I'm going to demonstrate the surgery. So sometimes you might see blood. So if you do not feel comfortable to see blood in the scene, then so please take care of yourself, okay? And then so far, anybody get any question for my presentation? Okay, then, so for the presentation, I will share with you with a different view. So let me see. Let me close this first. So I will share with you with different view, and so let me put something down here so you can see things. So I will share with you with a scope view, okay? And so you can see what's really happening clearly under the scope. And then I also show you the Doppler, laser Doppler. Laser Doppler view, okay? And then I also show you the laser speckle view, okay? And so I'll switch between, and then I might not be able to notice your question when I'm doing the surgery. And so put your question into the Q&A, then I'll try to answer that when I finish the demonstration. And in general, usually it's difficult to do the laser Doppler and the laser speckle at the same time, because for laser speckle, you shouldn't have anything on top of your skull. But for laser Doppler, we have to attach that probe holder on the skull. And so what I'm going to do today is going to prepare the skull for laser speckle imaging before I put the adapter on for laser Doppler. And then we would get the imaging of laser speckle to see all the blood vessels on the brain. And I will use the concentration of anesthesia, the isoflurane concentration, to change the blood flow in the brain. And so you will see how the laser speckle to detect all this change. Okay, then after that, I will attach the probe and then put the laser Doppler probe on and rotate the animal, start to do the MCAO, and let you see the laser Doppler blood flow recording curve. And then when I induce MCAO, I also pulled out the filament to let you see the reperfusion. And then we will flip the animal back and then remove the probe and use the laser speckle to do the imaging again, okay? And then you might, after MCAO, there might be some residues on the skull, a little bit. So the image quality is not going to be as good as the first one before we are going to try before MCAO. Okay, so that's the demonstration I'm going to do today. Okay, so right now I'm going to switch the small camera. Right now it's pointing on my face, right? So I'm going to switch to another one. So it would show you the other angle of our room. Okay, then so here's what we do. Then we have this dual head microscope. Oh, wait a minute. So the camera's power just disconnected. Okay, I put it back. Okay, and then so it's allowed two surgeons to do the surgery at the same time if the surgery is very complicated. And then also it's a great training setting. And we have 3 similar settings in the core, okay? And so if you guys are interested in get some in-person microsurgery training, and you can contact me and we can arrange that. And right now we also provide a service to do surgery in different people's vivarium. So we can also deploy surgeons to your facility to do the surgery for you if the animal transfer is kind of like a trouble, okay? And then let's switch to the scope view. Okay, and for laser speckle, it's important to keep the skull moisturized. So let me make it brighter. So do you guys see the view okay? Okay, good. And so I already prepped the skin. We prefer not to use the nair, not the hair removal paste, because we are doing some inflammation study, so we don't want anything might cause inflammation. So we still use the traditional way to clean their skin, and we will autoclave our instruments every day, and then between animals we will use the happy sterilizer to sterilize our instruments. And so for today, since it's a demonstration, I'll cut the skin a little bit more wide open so you can see the anatomy better. Okay, so once you open this up, then you see right now you can see the skull is actually kind of transparent. You can see the blood vessel down there. Okay, and then the first thing you need to do is you have to break this soft tissue. And if you do not remove that clearly, it would become a problem. When you try to fix the probe on the skull, it would fall off easily. But if you just need to do laser speckle, and that doesn't matter. But since I have to do the laser Doppler later, and then so I'll try to clean that better. And do you guys see the edge of the skull here? So behind this point is a muscle, okay? And so let me use a 3 rejector. To pull the skin away a little bit. And when the skull become dry, and you will see it's become pale, then you cannot really see the blood vessel anymore. Okay, so let's apply the saline to moisturize it. So I'll try to clean this up a little bit more. Otherwise, laser speckle is super sensitive. So if there's anything in its way, it would cause the speckle pattern change. So I'll make this cleaner. Okay, and then we apply the ceiling on. Okay, now I'm going to switch to the laser speckle view, and then from the other camera, the small camera, you will see how the laser speckle system looks like. It's actually quite compact, okay? And then I'm going to use the computer to turn the system on. And I'll switch the view to laser speckle system. Do you guys see the laser speckle system screen? Good. And so there is a red laser point, and that's help you to make sure your system is at good height. So you want to make sure that laser dot is right on top at the center. Okay, and then you will get 4 view. Okay, so what's really more interesting is the pseudo color pattern. Okay, and then you see that even with this distance, you start to see some pattern already. And then RWD system get an autofocus function can help you to get the image focused. Okay, and then we can zoom in more. Okay, and you see that we should adjust the animals a little bit. Like that. Okay, and then we will click OK. And then do the autofocus again. So do you guys see the pattern of blood vessel? And so for some area, it could be it gets too dry or some other reason. So you will see a spot that doesn't really show much. You see right now I apply some fluid, it's become better. Okay, and then I can push the animal up a little bit more. Okay, and you can decide what view you want to see. Oops, wrong mouse, sorry. So if we, because right now you can see for the real pattern, you cannot really see much. So real pattern is only to help you to focus and try to really get the area you are interested in. And so if we remove real pattern, removes, and only keep the pseudo color, then you can get a bigger view, okay? And then here is the fine tune focus thing. You can really try to fine tune it, but I do not have much time for that, okay? And then you can adjust the threshold. Okay, so you see, if you adjust the threshold, you might be able to see some smaller blood vessel. And I have tried more instruments, laser speckle, pyramids, and RWD system. And RWD system says provides the best resolution for small animal, for rodent study, okay? And for pyramid or the more instrument, they are more focused on human patient things. So their field can be bigger, but their resolution is not as high as RWD system. Okay, and then so after that, you can apply the ROI. So for example, if I want to look at this specific blood vessel, blood flow, you see it's give you the reading, and then you can apply another one to another area. Okay, then it start to give you the different one. Okay, and then what I'm going to do now is going to increase the isoflurane concentration. Okay, and so look at the baseline, they're about 350. So I start to increase the concentration, you will see the drop. And I'm going to record it for 2 minutes, okay? And if you look at the general picture, you probably won't see much differences, okay? But if you pay attention to a specific blood vessel, look at the color change or look at the curve of the blood flow reading, you see it's dropping now, right? You see right now it's dropped to below like 300. So it's around 275 for this, for both of them. Okay, and you can do similar thing with multiphoton. We have tried that. But with multiphoton, you have to fix the animal on the plate seriously because any tiny movement would screw it up. You know, but with laser speckle, it seems way easier, right? So you see somewhere it start to get dried out. So I'll just apply a little bit back. So if you are, you need to design a better platform, make to give it deeper fluid level, so it can stay with that blood level for a while. Okay, so right now you see that, and if I turn that off, isoflurane back to 2. Then let's see if we can see the blood flow comes back. You see, it's already detecting it. You see the curve is starting to heading up. So actually it's very sensitive. Okay, and so it's still climbing up. And you see the imaging is actually will become brighter. Okay, so I'm going to put the concentration to 2 so the animal won't wake up. And then here's, I'll show you if oh, sorry, wrong mouse again. So if I turn off the system to offline, and I import the image from what I just recorded, so you see it says it's calculating, so it's trying to accumulate to restore the data. Then we can do more things when it's done. And that's when I apply more saline on. Okay, so it's done. And then what you can do now is, for example, oh, actually what I'm really interested in is here. Okay, and then you can generate another ROI here. And you double click it. It says, are you sure you want to calculate? Then you click yes. And you see here, it's give you another analysis of that specific spot. Okay, and so this is the beauty of the laser speckle. And then so you don't have to do another animal to measure a different area. And so you can apply as many as ROI you want to. And you will not lose your original measurement or anything, something like that. Okay, so that's a good thing. And then you can also export this to time-lapse imaging, okay? So you can see the change faster. And so it's a very convincing way to present your data, okay? And so right now I'm going to switch to the scope view and start to do the MCAO. So then I'll push this away and have the scope back. And we'll zoom in. And focus. Okay. And some people is asking, can I tell them the coordinates? And the coordinates where I put the probe. And I think the coordinates probably doesn't really work well. It's because the scale we're working on is different. And I'll show you what I'm talking about. So let me do some adjustment first. Okay, so here's the Brigma, here's the center, okay? And our goal is to put the cat here, okay? And so if you're asking me coordinates, well, I don't really know because I don't really use coordinate to measure where I'm going to put it. And so this is the probe we're going to put on. And you see the size of the adapter is actually big, right? So it's about this area, like that. And I want the edge. Actually, we trim the edge a little bit so we can make the center of the cone closer to the edge. Okay, and then after that, can you guys see it well? Then we will apply just a little bit of instant glue for temporary fix. And then we'll mix the dental cement. And we use the Q-tip to apply the dental cement around, and also for holding skull. Just apply a little bit more around it to make it look like a volcano shape. Okay, and then it would take about 10 minutes to really cure. And so we do not really wait for 10 minutes. We would just rotate the animal to do the neck part. And when we prep the neck ready, then it's about to ready to insert the probe. Okay, so I'm going to zoom out. And then we're going to put the drapes on. Let me switch to another view and switch back because it seems the image become a little interesting, right? Okay, much better. Okay, and then we're going to find the inlet of the chest and then cut the opening. Okay, then so I probably should cut a little bit lower. Probably doesn't really that matter. Okay, and then we want to dissect between two saliva glands, okay? And then once you open that up, you supposed to see the sternal-hyoid muscle that gets the trachea underneath, okay? And you shouldn't see any big blood vessel yet. If you see big blood vessel like this, that means you're on the side. You're dissecting the jugular vein, okay? That's not where you should go, okay? And then let me get the rejector ready. So you want to pull the sternal-mastoid away. Then once you pull that away, you will start to see a pulsing blood vessel. Oh, someone want to know the draping, the plastic sheet. So actually it's a press and seal. We just have to sterilize that. It's cheap and efficient, okay? Then once you pull that away, you see something pulsing here, right? And then you want to dissecting this spatial tissue, okay? And then everything is actually underneath this thin layer of muscle, and lots of people would just tear it, okay? But we will try to minimize the damage so the animal can get better survival rate. So what we're going to do is going to pull this away. Okay, you don't have to apply tremendous strength to pull it. Let me get it focused again and zoom in more. And from time to time, you want to moisturize your tissue around. You don't want them to get dried out, okay? And then I'll make it brighter. Okay, and you want to isolate a little bit here. Then once you isolate this, you will see the bifurcate is here. Okay, and then you can use another retractor to pull the bigastric away a little bit, but not really necessary. But I'll do that so you can see the vagus nerve better. Okay. So let me move this to the center of the view. So do you guys see this white thing with stripe on it? And that's the vagus nerve. Okay, and then so right now what we're going to do, and you see this one, there's a big blood vessel here. That's vein. Okay, then common carotid artery is the one pulsing next to it. Okay, and so what I'm going to do now is to isolate the common carotid artery. Then you want to make sure you really isolate it, so you can apply a clamp here. And now I'm going to isolate the internal carotid and the external. The bifurcate is here. So you see these branches here. That's the one go to thyroid. And so that's the one we are going to burn. And then there's lots of branches of nerve running along with the artery. So you want to make sure it's free from the blood vessel. So when you clamp it, you do not really clamp the artery under the nerve with it. Okay, and I'm going to use a bipolar. A bipolar cauterizer, which would only burn the stuff that I grab on. Let me get it focused more. Remove first. Okay, so we burn that branch. And I'm going to check the animals. Its breathing pattern seems not perfect. Let me see what's going on. Okay. Oh, now it's super red. Okay, and you want to respect all these nerves. Of course, you can easily tear them, okay? But your animal will have more deficits. Okay, and then I'm going to use a small scissor, a pair of small scissors. To cut it. Okay, then after that, we'll run the 6/0 suture around the external. Let me get a suture closer to the field. Okay, so we will get loop, then we'll trim the loop. So we have 2 strings to play with. And 1 string on the top. Will be the one to tie it off the external. The other string will be used to make a loose knot for holding the filament we are going to insert later. Okay, and then you want to try to push this knot away from the bifurcate so you have a longer working distance. Okay, so for this part, it's done. Then so I'm going to put the probe on. For the baseline of cerebral blood flow. Okay, so I insert the probe into the holder, and I'll switch the view to the laser Doppler view. Why it's keep coming up? Oh, okay, so I click start, and you see the reading. And we change the scale. Okay, and so you see that's the baseline around 200 and maybe 60. okay? And then we can do the quick test to see if it works or not. So I'll just use my forceps to temporarily clamp the internal carotid. Then if that probe is at the right position, you should see some dropping. Do you see that? And so that means the probe works well, okay? And how do I insert the probe when the animal is in supine position? The animal is not really straight, so it's actually rotated a little bit, okay? So the probe can still get in. Okay, so right now I'm going to have my filament ready, the occluder. So here you go. And you see that it's just 2 millimeters long, but it's even longer than the external we can get, okay? And so some people get confused, it's, that's just way too long, but that's the shortest you can get, okay? And then we're going to apply, oh, sorry, so you do not really see the suture. So you see that suture? Okay, so that's the tip. And do you see what I'm talking about? It's quite long, okay, but that's only 2 millimeters. And so that's the shortest we can get. Okay, then I'm going to apply the clamp on the internal here, okay? And then after this, if we switch back to laser Doppler, you suppose to see some dropping. You see that dropping? So let me change the scale. Do you see? That's when I clamp it. And you see, even just by clamping the internal carotids can give you almost 50% of drop, okay? And in rats, it would only give you about 15% of drops, but in mice, it's like that, okay? So I'm going to switch back to scope view. And then I'm going to clamp the common carotid. So after that, we can make a small hole about 50% cutting through the external wall. Okay, and the residue of blood will come out a little bit, but it's not really bleeding. And then we would insert the filament into the external carotid. And you see that's all you can insert. So you have to tie this at the halfway of the tip. Okay. And then right now it's okay to remove the clamp on internal carotid. And then we're going to cut the external carotid totally. Okay. And right now we can make a U-turn. Okay. And then we're going to push our filament in. And we're going to tie it. Okay. And then now it's good to remove the common carotid artery. Okay. And then now I'm going to push the filament in. So I'm going to switch to laser Doppler view again. Okay, and you see that right now the blood flow is not going to back to normal because the tip is actually already partially occlude the internal carotid. Okay, so I'm going to change the scale again to let this go to kind of top of the okay, and so I'm going to insert it, and then you guys can notice that big drop. Okay, I'm going to slowly insert it. So that drop should happen pretty soon. Okay, then so you see that drop, it's not really as much as we want, but that's probably will be it. You know, and the animal I'm used today is a little bit older and bigger. And but right now you see the blood flow is actually dropped to 780 probably. Okay, and then so if I can try to push forward a little bit to see if it helps. And but like I said, usually once I hit there, it's not going to help too much, no matter how much you insert more. Okay, then so it's dropped from, right now it's like a 70 or 80. If let's say 80, remember the baseline is about is around 270, right? So drop to 70 or 80. And so that's about 66% or 70% reduction. Okay. And so right now, I'm going to pull out the filament. And also, this is just the beginning. If you wait for a longer time, for like 60 minutes, and it was drop a little bit more, okay? But you shouldn't keep insert more. You're just going to damage it, okay? And so right now I'm going to pull it out to see if we would get better reperfusion. Okay, so let me change that. Okay, then I'm going to change the view for scope view so you can see how I get the filament out, okay? So now I already put it out to the edge of the knot. So what are we going to do is to loose the knot a little bit so the filament can go halfway out. Okay, when it's go halfway out, you want to grab everything, then you can pull it out and then tie it at the same time. And so by this way, you can get the filament out without reclamping it, and also no bleeding at all. Okay, and then let's see how the laser Doppler reading now. So you see this one, it's not really like the textbook. But another possibility is because I start to prep this animal before I start my presentation. Okay, then so that's why this is happen. But like I said, sometimes the animal, different animal, it will be a little different. And right now you see it's actually get a trend to coming back. If I change the scale, you see it's actually try to increase a little bit by a little bit now. Okay, and then so that means it gets the reperfusion. If you do not see this trend at all, it's flat, and that means there's some damage at the base of the brain. Okay, and then right now I'm going to remove the laser Doppler probe. Okay, and then I'm stop it, and then I'll switch to the scope view. And I'll remove the draping and turn the animal around. And I'll zoom out. Okay, and peel off the adapter. You know, and you will see some residue of, oh, it's too bright for you guys, right? Let me adjust it. you see some residues of crazy glue on it. And then we can try to scrape it off a little bit, you know. But with that, the skull cannot get enough fluids to become transparent again. So for the, let's see if I can still get good laser speckle imaging. Okay, but again, like I said, usually if you are trying to do laser Doppler, then you do not do laser speckle. But for today's demonstration, we try to use just one animal for everything. Okay, and then we have a project. Actually, we actually make a cranial window for laser speckle, and you can get way better resolution. So the resolution can up to 3 micron per pixel. Okay, so that's a pretty decent resolution. And for more labs instruments, and their resolution it's up to 10 micron per pixel. And RWD system can go up to 3 micron per pixel. Okay, let me level the animal a little bit. And then use a retractor to make the skin a little bit open. Okay, and then apply some saline to moisturize it. Moisturize. Okay, a little bit more to have a pool of saline in there. Okay, that's good. And then I'm going to switch to laser speckle view. And so it still keep the last image we have. Okay, so that's the before MCAO, but right now it's not really MCAO because we tried to do the reperfusion already. Okay, and so I'll get the system online again. And then move the scope move it to the right area, and then start to see something. Okay. And let's try to get the real view, real pattern. And then let's do the auto focusing. Okay. And then we go to bigger view. And then we should turn off the white light and then turn off the indicator light to give us some better resolution. And actually, after the reperfusion, sometimes the stroke size supposed to have a little bit more blood supply because its body, well, it would try to compensate that. So you can label wherever you're interested again. Start review. Okay. And then I'll try to increase the isofluorine again. And then you will see it's dropping. So you see, start to drop. It's only like 30 seconds. It's already detect the change. Okay. And when it's recording or it's previewing the scale of blood perfusion, we just auto adjust it. Okay. Okay, so that would be the all demonstration I'm going to do today. So let me go to the Q&A. So you guys can let me see. Okay, so where's the Q&A? So the first question, which type of retractors do I use and how are they hold in place? And I use the magnetic retractor setting, okay? And then, yes, use the same thing for rats, okay? And the second question, I was wondering if we will be getting the presentation slides. Do you really need the presentation slides? If you talk to them, then, but if you can see the recording, and you probably don't really need the slides. And let me see if I can change the video to the other one. Oh, Okay, so you guys probably can see me now. Okay, and collateral vessels from the contralateral hemisphere of the brain or from ACA. I think if you block the CCA and still you get the blood flow from the collateral. Yeah, then that's possible, you know, because the way we insert that, you cannot really 100% if the area would not get other collateral blood supply. But that's also good because if your animal totally lose all blood supplies to that area, the animal probably would die. Okay. Okay, next question. Is it a must to have a Doppler to see the blood flow reduction? Yeah, otherwise, I don't know how do you know this really, you know. Then, of course, you can always use neurological score, you know, to use, but that might be the case that you might do like 5 animal, only 3 get a neurological deficit, you know, and then if they're just wild type, it might be fine. But sometimes, like right now, we are doing this aged animal, and each animal, even wild type aged animal, each one is like $300 something. Okay, then so we want to make sure our procedure can be standardized. Okay, and then is it the valid stroke model without knowing how much blood flow is reduced? I don't think so, but you can do one way to increase the N number a lot, then that might reduce the variation. But since we are a service core, okay, then so sometimes we even work on this precious transgenic animal, and they want everyone be a successful surgery. So that's why we want to do here. So what you have seen here would be like the high standard for doing MCAO. And how do you go about doing the stroke model in aged animal? It will be the same, okay? And then we just do the same way to do that. And then from our experience, then the survival rate seems okay. May I know what parameter we can use to describe the results when don't have laser Doppler? Well, yeah, then so that's a thing again, then there's not much you can do, you know, and of course, circulating, you know, like doing the neurological evaluations, then can give you some info, you know, but if you do not use laser Doppler, lots of times you are going to insert too much. Then when you insert too much, when you pull it out, some animal will just die or just get too much, too severe stroke. And some of them will become hemorrhagic stroke, okay? And then it's not ischemic stroke anymore, okay? Then, but from our experience, by this way, can give you most consistent results. Regarding the animal use, how's your experience doing MCAO in normal rats, young age rats, or, well, from our experience, then it's the same thing. And we think the time is how fast you can get the surgery done, okay? And because you can imagine, even you get the surgery done in 20 minutes, there's still 60 minutes ischemic time waiting for the animal. And then so the animal would get at least 1 hour and 1.5 hour anesthesia. So for aged animal, if you're doing it slow, it takes you 1 or 2 hours to finish the surgery, and then plus the ischemic time. then of course the animal might not survive. But for technically, for the surgery perspective, there's not much difference. But you see that we respect the tissue a lot. We try to minimize the damage. And you also see no bleeding for the whole surgery, okay? And so I think your surgical skill is the point. How many vessels can we measure simultaneously? If you're talking about laser Doppler and you don't even know, are you measuring a blood vessel or not? But if you are talking about laser speckle, and you can measure as many as vessels you want. Okay, TTC works in chronic ischemia. I would say no. The reason is because whatever cells, as long as they have normal mitochondria function, they can convert TTC to red. And in chronic ischemia, there would be tons of infiltrating cells there. And that means you would underestimate your infarct area. You know, you will see less, the infarct size seems not really that big, but actually it's bigger than what TTC can show, because part of it is because of this infiltrating cells in the dead area, they still turn the TTC to red. Then you cannot see that. So that's why we either use nasal stain or use the immunohistochemistry staining for the alive neuron. So like use Neuen staining, you know, or use the HE staining for chronic ischemia. But right now we use the MRI because the MRI is faster and the animal is still survive, then you can imaging them multiple times. Can you send us all the information of the tools catalog? Yeah, I'll try. Will there be a complete video later? You need to talk to RWD. They might have the copy. Is the photothrombosis model reversible with TPA? No, because photothrombosis would cause the damage of the endothelial cells. And tissue plasmogen activators, they only lyse clots. So if your blood vessel already get damaged, there is no way you can do it. Okay, and then what type of sex of mice? Yeah, this is male, black 6J. Why MCAO? Why the mice die pretty fast after MCAO? It's probably because, well, there are a couple of questions. How long does the surgery take? Do they lose lots of blood? Do you keep their body warm during the surgery? Do you make the injury at the base of the blood vessel? Okay, so all these factors would be matter. And then from our experience, usually they do not die, almost 100% will survive. Can we use dental cement instead of glue in fixing the laser Doppler probe? That's what I'm doing, right? And so I use both. And so how much drop of cerebral blood flow would consider a good MCAO? And so usually from our experience, it's between 65% to 80%. And then the size would pretty consistent. And so again, the reading of cerebral blood flow, it's also affected by where do you put the probe on, okay? And then so sometimes that's not the real one for to do the evaluation. to tell how much it's really, how severe the infarct is. You know, because if your probe is a little bit off from the MCA territory, and then it might not totally correlated to the infarct size, what you're going to get. Next question, if you do not have laser Doppler, well, it's again, okay, so I have answered that. I sometimes performed vascular and induced the hemorrhage thing, right? This sample must be excluded. How can I reduce this accident? There's a great way. So hire us to do the surgery for you, and we can make it done really fast. So basically, we can do 15 animals a day. So if we are there for a week, 5 days, then so we can give you 75 MCAO, okay? And then if you want to do that by yourself, it's just, you need lots of practice to be able to get it done, okay? And sometimes it's difficult. Then so that's also the purpose of the core. And the surface core, since we always do different type of microsurgeries to keep our skills sharp, okay? And then so that's why we can still maintain the skill. And for different researchers, you know, there's no way they can do the surgery every day. They might do surgeries for a month and need to do other analysis, other experiments. Then when you come back to do it again, you kind of feel like from the scratch again, you know, then so there will be always learning curve and to get the consistency. And so that's, sometimes it's difficult. And so that's why we established this surface core here. And then so then people can get really consistent animal model to make their experiments more smooth. What about different age animal, 2 to 12 months? Does filament size need to be variable? No, we use the same size. Is it necessary to put the clamp in the turgoplatin? No. Like I said, after 50 animals, then you would get it without ligate turgoplatin. And if you have to deal with turgoplatin, you have to dissect more. And sometimes you will just make mistake. And could you please tell me isoflurane and oxygen ratio? And so for induction, we use 3 to 5%. And for maintain through the surgery, we use 2%. 小鼠造膜过程以及缺血过程和再灌程对温度的控制是怎么样的？ So someone is asking, do we have, what about the temperature control for the ischemia and the reperfusion? I'm not sure, are you talking about the body temperature control or other temperature control? But in general, all our animals would be on the heating pads to keep the animal warm all the time. Yeah. Could you please inform us about the analgesics that we should give for this type of procedure? And well, we use, you can use this NSAID like carprofen, you know, but if you are using carprofen, you have to give them like between every 4 to 6 hours. Then I don't think you want to come to do that at night. So still, like we usually use buprenorphine for that. So we only need to give them every 12 hours. Like the first thing when you go to work and the last thing before you leave. Can you use laser speckle to measure lesion size? Technically, yes. Then so you can kind of, but it's not going to be that precise because what you're really measuring is based on the blood flow, right? And then the blood flow shows low at the moment you measured, doesn't mean it's going to be the infrared area, and you cannot also tell if that's going to be a penumbra or going to be in the core. So laser speckle is more usable for doing blood flow dynamic study. What brand laser speckle are you using now? I think RWD's people would be mad if you don't know what brand that is. And if just use Black 6, can you order the animal in your place and do the experiment for other institutes in United States? Yes, we can do the whole thing. So we can do the MCAO, do the treatment for you, do the MRI for evaluation, and do the neurological scanning. Then we can do get the brain out, do the whatever staining you want, and do the PCR for whatever cytokine you want to measure. So we can either do just for surgery only or the whole packages. I do research on hemorrhagic risk evaluation in reperfusion after MCAO. I wonder if you have any experience on making differential between cerebral hemorrhagic due to surgical procedure and that reperfusion result. Well, then, so we do not really study the particular topics of hemorrhage after stroke. But if you get access to MRI, you T2 weighted, sometimes you can see the hemorrhagic transformation, okay? During occlusion, mouth should be anesthetized. Well, it depends. Some people will wake them up, but we just want to make sure the laser Doppler is still measuring. And so our way usually would keep the animal anesthetized, but sometimes you don't need to. And laser Doppler holder diameter. So for the probe diameter, it all depends on what probe you're using, okay? So we just choose the one can hold our probe perfectly, but if we are not using the same needle probe, then our probe is not going to, our adapter is not going to hold your probe well. After MCAO procedure, do you give them saline to increase survival rate? We do not, unless we have some bleeding issue. Then, but we do give them water and the soaked pellets to help them to eat, because after stroke, they might get confused. So they cannot really access their water source in the blood, in their cage very well. Okay, then, but it depends on different animals' condition. But in general, we don't need to give them saline unless they have bleeding issue during surgery. Okay, and then so that's the most questions I have answered. Okay, and then it's perfect timing now. And so you can find my information online, and but if you have more questions, then you can try to email me, and then I can do that. Okay, then so right now I'm going to pass the microphone to MC. Okay, so the RWD people will take care of it. Okay, yeah, and thank you very much for the participation today, and then hope it helps.
Well, thank you, Dr. Chen. Thank you for today's webinar. And where's it
So if you do not get your question, before they cut off the connection, I can still answer. Okay, let me see. What can I, oh, where can I see the video recording? Well, you need to ask RWD people, okay? Do you use analgesics during surgery? Yeah, well, we usually give them after surgery, so before they wake up. Do you travel to other institute to train investigators? If so, how much do you charge? We can go there to do training for different people. We can even do surgery for you guys. And then, so how much do I charge? This depends on where you are, okay? And then we can talk about that definitely if you have the need, okay? Then so try to go online, find my info, okay? So my name is Jay, YI-J, last name Chen. And so I work in UC Davis. So if you use Cardiovascular Research Institute, then you will be able to see that. And 请问若要看手术后第7天 So the question is, if you have to see the TTC standing at 7 days and have to consider the fatal rate, and what's the occlusion time I would suggest? And so in mice, we would do 60 minutes, okay? And then some people is asking, they do put the filament in, but sometimes they cannot feel the resistance. Yeah, like what I just told you guys. And if you can only feel the resistance when your filament is more rigid. But if it's too rigid, when you pull it out, you're going to damage the base of the blood vessel. Then so you're not going to be able to do that. Then so that's why we use laser Doppler to control. Just wondering, do you ever observe different neurological outcome if we use different type of anesthesia? If yes, any recommendation on the type of anesthesia? Well, we do not use other type of anesthesia. And because isoflurane still be the easiest one. Then we don't want to use, before, maybe 10 years ago, we used Penobar and ketamine, lizoline. But if you use this injectable one, then you have to wait so long before they wake up, okay? And then isoflurane so far is still the safest way for us. But of course, isoflurane is going to affect the cerebral blood flow, for sure. You know, then so, but that's also a reason why you need to have control group. Before the insertion, what instrument was used to block the flow? We use a blood vessel clamp for that. What is the mortality rate of reperfusion model? What about the permanent model? For a permanent model, you can imagine they are not going to survive for too long, okay? And then so usually if we are doing permanent, we only do for like a super acute study. But for reperfusion model, they can live up to a month without any problem. Do you have plan to do webinar for vascular implantation like graft? I can do that if someone is interested. Be a sponsor, definitely. How long is the time from occlusion to reperfusion? In mice, we would do 60 minutes. In rats, we do 90 minutes. And from your experience, what is the best time of duration? Like I said in the presentation, you have to try because we might use different strain of animal. Okay. And how long you keep the filament inside the artery? So that would be the ischemic time. Okay, 60 for mice and 90 for rats again. And how percentage to succeed of MCAO in rats by planting the filament inside the carotid artery? I don't know. We never really tried that. We always insert the filament in from the external carotid. Okay, and craniotomy, distal MCAO method, then we usually do not do that, because if we do that, right, you have to cut the temple bone and the muscle, scrape the muscle away. And actually, when the animal wake up, they suffer a lot. And that would also interfere the neurological evaluation. Okay, then so that's, we do not really do that. How can I find the precision position for this? The precise position for the surgery? I don't really quite get your questions. What kind of neurological tests I did? We do, depends. So basically, we at least would do a 14 reflex testing, okay? And then but we also get equipment to do the rotor rod, do the balance beam, do the step, and do the adhesive removal evaluation. Okay, and then my team, Garcia test, modify local scope. Yeah, that's right. I would like to know how I keep the probe on the skull with the animal lighting on this back with the probe stick out. Now, like I said, the animal is actually rotating a little bit. So its probe is actually here. So you can still insert your probe in there. Okay. Are these corded probe? Yeah. And so it's a needle probe like this. Okay, rigid metal part. Then inside gets two optical. How about the incident rate of hemorrhage due to surgical procedure? 0. The outcome of MCAO are always vary in terms of neural behavior. Even after we control the weight and age of the rats, we do believe that is due to the collateral. That's the brain. Do you have any suggestion in minimize this variation? Okay, then so you should choose the strain of animal carefully. Okay, so we usually use Worcester rats for the MCAO. Then so their anatomy is more consistent, and also they also get better. They can tolerate the MCAO better. Do you use any? And oh, I already answered that. Do you? Okay, I think I answered all the questions. So, 请问如何固定老鼠? How do I fix the animal on the table? No, we do not really fix it. We just use a tape on its tail to make sure its body is straight. Is there any surgical reference in interference? Chemical other factors you can identify? Well, usually we do not. Well, we have been doing this so long, so, and I show you how we do it. So we believe this is the best we can do. So you can try to follow exactly what I'm doing. Do you think the MCAO soft intravascular due to the animal's body temperature? I don't really quite get your question. Do you think the MCAO soften intravascularly due to the animal's body temperature? Okay. And so
question, right? Okay, so if there is no other questions, and I think that would be it for today's seminar. And then thank you again for the participation, and hope it helps